Thank you so much for inviting me here today to talk about something that I am extremely interested in. It's been fantastic to learn earlier today about some of the work of the centre and the overlaps in our interests, and I'm hoping for some really interesting discussions after I talk a little bit about this sort of critical look at co-approaches. So what I intend to talk about is, I'll start a little bit just thinking about, well, what are co-approaches? I think probably a lot of us know about that, but just to sort of give us a good basis on which to have this critical look. Think a little bit about, well, why are we even talking about these things? Why are they important? Why should we be thinking about them? Oh, and then also some reflection on the challenges. So this sort of thinking critically about co-approaches, what things do we need to consider? Where might we have some challenges in making this happen? And what might be potential limitations to the approaches as well? So beginning with what are co-approaches, as Anna was saying, co-production, co-design, co-creation is what I'm going to focus on. But they're not the only terms used, and I think we have some difficulties sometimes in identifying what are we really talking about when we talk about co-production, co-creation, co-design. There are overlaps between some definitions that we see about these terms, and they're sometimes used interchangeably. And there's a link with approaches with regards to participatory research. Some people talk about how participatory research is sort of an approach to research, and co-production, co-design, co-creation are methods that we use that are participatory in nature. And I also put citizen science on the screen there because when we're thinking about co-approaches within research, sometimes we're interested in a really collaborative approach where researchers aren't the only people doing research. So thinking about citizen science, that's an approach that very much encourages and uses the public as researchers, as scientists. So I wanted to put that there as another kind of consideration for us as well. And then I also thought it would be helpful to think about the very many terms that we have when we think about who we're working with in these co-approaches. So ourselves as researchers, but who else is part of that process, who's part of that approach. So stakeholder is quite often a term used thinking about people who have a stake in our research, perhaps the people who our research is for. If we're thinking, we have a health focus here, we're trying to bring about changes to people's health, we might be focused on a particular health problem. So people who have a stake in that health problem, which might be the population who are trying to change the health problem in or improve health for. Sometimes we hear the term service user, so people who are users of the services, the health services, for example, that we may be working with. But also if we're designing interventions to improve health, then maybe the people who would be the users or recipients of those interventions. We also have practitioners here, so thinking about people who may be involved in supporting the target population or the service user through their practice, again to improve health, whether that's working in health services, whether that's working in community services, but with that focus on doing something in their job that's linked to our research, the things that we're trying to change in health. So we've got the public and citizens more generally over there. This might not always just be members of the public who are the target population, but could also be the general public more broadly. So we may be interested in bringing about change for people with type 2 diabetes, but we might also want a wider public input or perception beyond that population. And in citizen science, that's very much the focus of general citizens' populations. And I've put co-researcher at the bottom there, this idea of, again, people who aren't researchers in their day jobs, but potentially becoming involved in research through these co-approaches. That's a term that we see used sometimes as part of citizen science, but more broadly as well in our co-approaches. And finally, expert by experience. And this starts to move into this discussion about, well, why are we doing co-approaches? One of the main reasons is to bring particular experience, whether that's of the health problem, of the target population, of the context and setting that we're working with. As researchers, we may not always have that particular experience and expert knowledge, and we're looking for people who are experts in the lived experience of a health problem or of working in the communities that our research is happening in. So thinking about the people that have that expertise that can be brought into a co-approach. And I think it was mentioned in the advertisement for this talk about, there's a growing interest and emphasis in these co-approaches, and I was interested in just having a look at, what does that look like in the literature, in the research literature? I like to do a literature review. I am a researcher after all. So first of all, I went to Web of Science, which is not an exhaustive database, but it captures quite a lot of health research in particular. And I searched for co-production, co-design, or co-creation fairly broadly, so in abstracts, in keywords, in titles. Oh no, you can't see the graph. I think it's just very, very pale. Oh, that's a shame. It is there. So essentially what you can see, what you would hopefully see on this screen is, it's really strange. It's supposed to be there. Okay, essentially we've seen a massive increase where if we look back to the early 2000s, it was like here, like 100 or so papers, and it has very steeply increased in recent years. So 2002 is what I've highlighted because 2023 isn't over yet and may still increase. So in 2022, there were over 5,000 papers that included these words in either their title, abstract, keywords. So not necessarily writing about how to do co-approaches, but talking about using them in their research. We used a co-production approach, we did this co-creation. If we do focus it in on people who've put this in their title, then there are fewer, but there's still a lot there. Again, with a very similar increase exponentially sort of since the 2000. And I'm going to talk about a few very current papers over the next few slides, but I will give a caveat that I've not read all of these. So I might miss things, and I'm interested in hearing from people in our discussion about interesting things that you've seen and ideas and approaches. I shouldn't have touched that. So let's think of a couple of definitions, and I'm starting with co-production because in the UK, I think we have a slight prominence of this term potentially, or at least historically we have. So particularly in health research, but also health service design and health service quality improvement, co-production has become really popular. And that tends to be the term that we see used. It's got quite a long history, so it doesn't come from health research or health services. It comes more from urban governance, for example, in the USA in the 70s. But this is a quote on the screen here that talks about it specifically with regards to health services. So this idea about it being more than consultation, and talking about people who have particular skills and experiences to support improving health services, and doing that with a shared responsibility. So not just being something that professionals do, but there's a shared responsibility of other people, particularly thinking about patients here. I've got a couple of other quotes there, thinking about involvement of service users is the term they use here, not just in design, but also management, delivery and evaluation of services. And more particularly which are of consequence to them. So this idea of that having a stake in the service. This idea that should we really be producing services, producing interventions, doing research to people and about people, or should we be doing it with them? And I'll come back to this in a minute, but this idea that we talk about service users, I mentioned earlier, practitioners, this idea of people who may deliver services, or if we're developing interventions, maybe the people implementing those interventions, but also people who fund them as well. And I was just going to touch on the broader field of public involvement, stakeholder involvement, of which again there's lots of literature and guidance about. But this idea of when we're doing co-approaches, we're really looking across to these sort of far ends of these continuums where we're not purely consulting with people or asking for information, but we're working collaboratively in an empowered way. So there are a couple of different sources of those sorts of models and ideas of doing things at this end of the spectrum or at the top of that ladder. I don't entirely know why co-production is above co-design on that ladder. There's not a definition that goes with it, but that sort of, it's putting them above engagement consultation. So it's like a step beyond doing something collaboratively. If we think about co-design and co-creation, again, as I said earlier, I think we're at a point in the literature where, and practice, where there is still interchangeable use of some of these terms and perhaps less agreement on what they mean and whether they're the same thing or whether they're different. This is a perspective put forward by Vargas and colleagues last year that sees co-creation as an umbrella term in which co-design and co-production are sort of encompassed. And one of the things they talk about is this idea of a timeline of the work we're doing, whether we're looking to improve a service or address a health problem or whatever that is. We have sort of a period of sort of needs assessment or problem definition and understanding that requires identification and analysis and definition. And then we might have, like, we may be designing something, a solution to that problem. Ah. Oh, is it a screensaver? Yes. Sorry. I'll carry on. I remember what it says. So at the other end of that timeline is then putting things into practice after we've designed them, implementing or realizing, as it says here, and then evaluating. And they see co-design as being this first initial stage of a co-approach, and co-production being something that happens when something's already been designed. So their sort of separation of co-production in this model is the idea that co-production is something that we do when we already have something specified. So there's less room for making shared decisions. And so that was a little bit strange for me because, as I said, in the UK, we use co-production probably the most at the moment, or have historically. And I was thinking, well, co-production, some of these things for me are co-production. Maybe that's my understanding and my definition of co-production. They're not, I wouldn't say that we only respect and value knowledge, but we have a more broad understanding of respecting co-production. So I think I was really interested to see this and starting to think about, well, maybe what do these different things mean? And this is based on, what we've seen, the ways in which we've seen co-production and co-creation and these terms used. I think in reality, we're not there yet with a pure agreement on what everything is, and lots of still interchangeable use, but I feel like maybe we're moving somewhere in trying to figure that out. And I'd be interested in people's thoughts on that later as well. So I said this idea of co-production, and the same with co-creation and co-design, they're not necessarily new ideas. They're especially not new ideas outside of health. Another thing that we've been quite interested in is where these kind of approaches are used in other fields, in other disciplines, and in practice. And particularly looking to manufacturing and product design, where of course if you want to develop something for consumers to purchase, you want it to be the most relevant, useful thing so that they will buy it, and so that it works for them. So there's a lot of what's called sort of user-led or user-involved design and research. So a couple of examples. There's something from in the 70s called software lifecycle development that has this focus on, well, you really need to understand the needs of the user or of the system that the product or the software would go into, but also that you would have what's essentially a process of feasibility testing. You have these phases of testing out and debugging potential problems with it when we're first testing something out. And that's similar to usability engineering as well, and more recently I've become familiar with design engineering, which I think is similar. This idea that the more effort we put in at the beginning, the less cost we'll have at the end. And this idea of, again, really understanding the user, and they talk about the setting here, where the product will be used, how it will be used, but then involving those users in the development of the software, so helping test it out and feeding in their opinions and their feedback. And then a continuous and non-linear, so more like a cyclical approach to quality improvement, to very rapidly assess the viability and improve the product. And there's an overlap with approaches such as design thinking as well, which have also been used in product design but are being used within health service design as well. And again, there's similarities here in terms of really getting to know the needs of the user, what might be barriers of existing services, existing products, and what might be facilitators, narrowing down to the most important things, creating ideas, testing ideas, and building a prototype. So Anna's mentioned earlier some of my work on co-production, and probably the thing I'm most known for is this co-production framework. And we were really interested in that idea of sort of little bits of testing and iterative design as part of a wider development process that was also collaborative. So this is what we ended up designing, and I don't have the time today to go into lots of detail on this. Happy to talk to people about it later. But this idea that we may use different methods at different points and with different groups. So we had this phase of consultation, so it wasn't collaborative, it was more sort of, can you tell us about your experiences, your needs, your what you think are pros and cons of the current situation. Then we had a phase of much more collaborative, what we called co-production, with a particular group that we, through this phase, identified as most important, that helped us to draft an idea of an intervention. But then we went through this prototyping phase of, well, let's go back to some of the people we spoke to initially, or the groups, the populations we spoke to initially that weren't involved here, and do some testing and see whether actually what's been designed could work, has any issues, and that idea of iterative testing with different groups to reach a kind of final version. That was quite a long time ago now, and things have very much moved on. So I was going to cover just a couple of more recent developments that I've been looking at and think are quite interesting and helpful in our thoughts about, well, what is it that we're doing and why is it important? So Leask and colleagues in 2019 were trying to develop, again, particularly in health research, principles for a more systematic and reproducible process. They talked about co-creation. So they brought up some interesting things that you'll see over the next slide or so. They're quite common themes that are coming out in the literature with regards working in a transparent way in these collaborative approaches, trying to work with a diverse group, promoting equal rights across the group where there might be power imbalances potentially, and how we might do that. And they highlight evaluation as well, so evaluating the approach. So they talk about 3 phases of co-creation: planning it, conducting it, and evaluating it. My colleague Hayley Reid in Decipher, and some other Decipher colleagues as well as those from elsewhere, as part of her PhD, conducted a systematic review of co-production, specifically in school health research, in education settings. But some of their findings were quite would be more broadly applicable for our thinking around co-approaches. In particular, thinking about what the core functions are and core aspects are of these co-approaches from the different versions and examples that we see in the literature. And again, we see similar things such as how we might try and have shared decision making and promoting and working with diverse groups that represent our populations. They also talk about how co-production, particularly in the education system, but I'm interested in how we think of this outside of education systems and perhaps in the health system, can happen from an external source and be an external people supporting the co-production and then leaving, or can build capacity for co-production in the system, either on an individual level or on a system level. So there's some quite interesting ideas there that I'd be interested to explore more. And then Smith and colleagues in 2022 conducted a scoping review, again, co-production in health research, and had a few lessons for future co-production practice as well as research. So they're talking about, do we need some sort of guidance? Do we need to come to an agreement on what these processes are? They also talked about recognising the skill set that co-production or co-approaches require, and thinking about how we skill people up. So a little bit of a crossover with the idea of capacity building in the above paper. And also recognising as within research, within academia, some of the institutional and funding arrangements that are required to make co-production happen. We spend a lot of money on things to make big evaluation studies happen. And sometimes that same resource and support is not there for co-production, co-approaches in our development or even in our evaluation. So there are barriers there that need addressing. And I've already mentioned Vargas and colleagues from last year with the diagram I put with the sort of co-creation seen as a more umbrella term. So they talk in more detail in that paper of this idea of that framework, including that timeline from initial identification to evaluation. Grindle and colleagues did a systematic review of co-approaches in health research, specifically linked to knowledge mobilisation, that particular focus of knowledge mobilisation. But again, some broader sort of ideas from that in terms of the different types of mechanisms that we see in co-approaches, kind of reflects some of these that you see in Leask and colleagues' paper, and also the different activities that we might see. Kind of a focus on workshops and meetings being a main activity, but they talk about some others. But they highlight, again, a lack of evaluation. And Messi et al. This year have conducted a systematic review to explore the theories that underpin co-approaches, specifically looking at co-production, co-design and co-creation. And they sort of apply Vargas et al.'s definitions. Finding that whilst we have all this literature out there, not very much of it talks about underpinning theory. And so maybe that's somewhere where we need to think about and talk about a little bit more. 6 theories were identified in the review from, I think, 10 papers. Empowerment theory was cited the most, like 2 or 3 times. So that again, that focus on those empowering collaborations and relationships. So I've probably kind of touched on this already in talking about some of those papers and talking about what these things are in terms of, well, why should we be doing it? And I guess it may be a little bit obvious what the sort of the rationale for it is. We want to avoid producing things that are not useful. We want to avoid producing things that are not implementable, as health researchers at least. And I think particularly that idea, like, why would we spend a lot of time developing something that just can't be done in practice, and that our target population won't engage with? There's this sort of quite broad rationale, and that kind of just makes common sense. So we were talking earlier about sort of Medical Research Council guidance is used quite a lot in Denmark. So this does mention co-approaches. It's not in the model, but engagement of stakeholders is one of these core elements of whether we're developing an intervention, testing it out, implementing it, engaging stakeholders at all phases, not necessarily co-producing, co-creating at all stages, but having that engagement throughout everything that we do. They do talk about co-production in a bit more detail, and this links to some of that rationale for why we should be doing it. They mention, as I said, about the level of engagement that we do and where we co-produce may differ depending on where we are in those stages and depending on the context. But they emphasise that we should be focusing on co-producing our interventions. So perhaps this idea of it's quite important at the development phase in particular. They say about open processes, so reflecting some of that other literature I just talked about, but they also say in ways that do not compromise research priorities and integrity. And I'll come back to that a little bit later because that's probably a bit of a tension that we have in our co-approaches. But they sort of frame the importance of stakeholder engagement more broadly as what the risks are if we don't do it. So we may not understand the problem broadly enough. We may be too narrow in our focus. Our intervention may not fit within the context that we are designing it for. It might not be feasible or acceptable. And they also talk in regards with evaluation that outcomes may not be meaningful or important or relevant to the target population. And practice and policy as well. So these things probably go without saying at this point based on what I've talked about already. These sort of different rationales that we have for co-producing, co-creating, co-designing. I've put co-producing at the title here because these rationales are taken from a paper by Catherine Oliver and colleagues, and they use the term co-production. But I think we could agree that perhaps these apply to all of those co-approaches with regards the utility, what we may get out of that process, at least as researchers and for our interventions, becoming more relevant, being more relevant to the population, being more appropriate for the health problem, for the context and the setting, being more feasible, particularly to those people who have to implement them. And particularly thinking about context specific and fitting within the existing system. So that idea of, we don't want to design something, really, we don't want to invest a lot of time and resource and money into something that's just never going to work in practice. No one's going to engage with it. There's also a normative and political imperative that supports the use of co-approaches and stakeholder involvement more generally. We're often using, particularly in the UK, the majority of our research funding for health research is public money. So we have a public duty to use that wisely and in the most efficient and useful way. So again, we want to develop things that will have the most chance of being useful. But also the importance of involving people who the research is about in that process. That they're given a voice, they're given a say in what happens to things that impact on them. And the potential benefits of that is that it may be more credible, more legitimate and relevant. But beyond those benefits, it's argued as something that we should be doing as sort of a public and civic duty. I've talked about stakeholders quite a few times, and thinking about this idea of, well, why do we do it? We may work with different groups for different reasons in terms of what they could bring to the co-production, the co-approach. And I tried to sort of capture some of that in this table here, thinking particularly we've talked about service users, target populations, the people who would receive the service, receive the intervention that we're designing. And I mentioned earlier about that lived experience of the problem that we're trying to do something about, that they can bring, and they have the expertise and the experience in that we most likely don't have as researchers. That can help identify what's most important to prioritise or focus on, what's most relevant, and can help with things such as acceptability of the intervention and engagement with it. And we've talked about like practitioners or people who maybe need to implement the intervention. That can be helpful in terms of thinking of the context that we're working with, their existing knowledge of working with the target population and what's been tried a million times and has never worked or no one ever engages with. But also possibly their training needs if they need to implement the intervention. What would they need to do that? And this may help with things such as feasibility, fidelity, buy-in. If we're working in health systems, there may be another level with regards to our implementation team. So people who have more management responsibilities and may know more about the capacity and the resource to make things happen. So that can be particularly helpful in understanding structural barriers and trying to address those, thinking about adoption and sustainability. And particularly thinking about sustainability as well. I mentioned earlier people who might fund the intervention, but thinking broadly in terms of wider policy stakeholders, we don't really want to be working with implementers and target population on all these interesting, innovative ideas that are important and feasible to them. And then we're told, well, we can't do that, there's no money for that. And your co-production was a waste of time because that's just never going to happen. So actually the involvement of people who can bring to bear some of those constraints, whether that's before the co-production process, whether it's separate stakeholder engagement or if it's part of it, but an important thing that we may need to focus on. And I've put this kind of other box at the bottom. For us in Decipher, we do a lot of work with children and young people. And it's very important for us to both understand the child's experience as well as parents. And working in school systems, not necessarily just people who will implement, but other people within the school system as well. So there may be other people that can understand those structural barriers or acceptability issues as well. So I'm just going to finish, as I said, with some reflections on challenges of using co-approaches. And I've touched on a few of these already, but we'll kind of try and bring them together. First, I was just going to go back to that paper by Catherine Oliver and colleagues in 2019, who actually, their paper was called The Dark Side of Co-Production. They were particularly thinking about some of the challenges and costs of co-production or costs to co-production. So they present some interesting discussions around costs and challenges, both to researchers, to research, and to stakeholders, as well as practical things as well. So they talk about some quite important considerations with regards, I mentioned earlier, we would need to dedicate resource and time to this in the same way that we do to our other elements of our research, and sometimes that doesn't happen, or it's not available, or it's not supported by our funders. They talk about cost to research, so this thing that was in the medical research guidance as well, around credibility and utility, and this idea of, well, do we favour scientific evidence and sort of rigorous methods more than stakeholders' opinions are valued, and what does that mean for the outcomes of our research? And there's a real tension around what gets published and what gets funded and sort of supported. But they also talk about costs to researchers, both in sort of developing and managing relationships and that investment of time, as opposed to other things that researchers should be doing and are valued for. And so they kind of conclude around having to make decisions about at what point, where we can co-produce and where we might use other methods, where we might be limited by some of these constraints. In a follow-up to that paper, Williams and colleagues did an in-depth critique of Oliver and colleagues' paper about some issues that they saw within this, and particularly some of the definitions around what co-production is, and kind of more of a focus on engagement with practice and organisational stakeholders, more than thinking about working with the public. And that there are differences and different challenges and things to think about between these. And one of the things that they highlight is that this idea, again, of academia and some of the structural inequalities in place that can really be sort of the underpinning issues rather than those challenges. So talking about poor research practice more than it's the co-production or the co-approach that's the problem. And they say this is partially an issue of a term they use called co-ubiquity, which is this idea of this increased appetite and emphasis on participation in research generally, and that growing terminology of co-words, and that can mean that sometimes we conflate meanings and practices from different traditions and may lose some of the meaning of what co-approaches really are when they're sort of combined with other forms of collaboration or involvement and engagement. And that some of these really important egalitarian and empowerment elements of co-production can really be lost, particularly when we start thinking about all the challenges to researchers and not necessarily to everybody else who's involved. So I had a couple of things to add to those, and I've mentioned already some of those. So we've talked about open approaches, being very open, being sort of working in equal partnership within our co-approaches. But sometimes it's difficult to balance that with constraints of our research if we're trying to be methodologically rigorous. And how do we balance those things? What do we give more weight to? An example is in the study that we conducted where we developed the framework I showed previously, we had a very collaborative relationship with the implementers who were involved in the co-production of the intervention, to the point that we had really high commitment and buy-in as a result of their involvement. They had a shared ownership of that intervention that they developed more than we did as researchers. Their experience with the intervention we were adapting was so important to that development process. But then there came a point where we're like, well, we need to do a feasibility study now, and really you need to go and implement it, and we need to measure the fidelity of your implementation. And all of a sudden, if we were going to follow that protocol as we had set out, they suddenly need to stop being part of the co-production team, stop being part of this development, and go and do their job, and we'll just watch them and measure them. And there's a real tension and strain on just those relationships, but also they would like to keep thinking and refining the intervention as they implement it, but we're saying, oh, just implement it as it's written, please. And there's real tensions there. I don't necessarily have all the answers to these things, but just reflections on things that we come up against. And linked to that is this idea of experience versus evidence. So we were talking earlier about, well, what do you do if you've got an evidence base of things that we know that work, and the things that are coming up in our co-approaches are the opposite of that, or kind of contradict what the evidence says? What do we do? And there's different things that, approaches we can take in terms of bringing the evidence into the conversations. But someone I was talking to yesterday was saying, well, we've got loads of evidence in physical activity, for example, of if you do these exercises, your health will be better, but nobody does it. So what's the point of having that evidence? And maybe we need to understand more what people might do and what would be more appropriate and acceptable to them and easier to do, more feasible to do, that then may also have health benefits. So it's trying to get a balance between that tension. I've got what happens after the co-work ends. So again, this idea I talked about, when you might stop co-producing or co-creating and then need to do something different, and that, what does that mean for the relationships built? There can be really positive things created out of co-approaches, and even if it comes to an end, new relationships might be formed that continue and have a ripple effect of benefits. But if we've developed something that really fits the context and really fits the population because of the collaborative approach to doing that with that population, with people working in that context. For how long does that remain the case? And at what point has the context evolved? Has the problem and the population evolved to the point that we've kind of lost that? And it's more of a general issue in intervention research from a complex systems perspective. But it's a consideration for our co-approaches as well. Would we do it again? Would we need to revisit it? Again, we've had that in the intervention I mentioned earlier from our framework publication. That team that we worked very closely with, a lot of them have moved on to other jobs now, and that's quite common, particularly in health services. So that buy-in and commitment, even though it may still be a relevant and feasible intervention, there's not a team now who've been involved really in depth with the development of the intervention that are really committed to it and have a real shared ownership. It's new people who were never involved in that process. A couple of final things I realise are pretty much at time. Ethics and data protection, this is something that I think is different in different countries as well. But the whole approach of, if you want to publish and talk about your research that has involved co-approaches, you're often asked for your ethics. And that, you've probably got an informed consent process for your participants in the evaluation or feasibility work, but you may be asked about, well, who are these people you're talking about? And did they agree to you publishing this information? Did they agree to you talking about what was discussed in the workshops or whatever it was? And there's a bit of a tension of, well, if you're trying to have an equal partnership, but then you're a researcher saying, please sign this form so that we can, talk about it in the future in a public sort of open sort of platform, it again has sort of potential issues. And I think I spoke to somebody recently who said, if it's qualitative research, we don't need any ethics, and co-approaches would be part of that, so we're fine. But then they have challenges publishing that work because the publishers say, where's your ethics statement? So I don't have the answer to that. Thinking about, the data, is it data that is part of our discussions? What happens in our co-approach? The discussions that happen, the information that is developed, the idea for the intervention, is that data, and do we have to treat it as such? So I won't go into detail of PPI versus co-approaches, but there is debate in the literature about how similar or different they are, and whether, how much we should see them as similar and different things. And finally, recording, reporting, evaluating. So it's been highlighted in some of that literature that we don't evaluate enough. In terms of, we don't really have an evidence base, despite all these sort of common sense things about making more feasible, relevant interventions that you would then hope would be implemented better. And if they're implemented better, hopefully they've got better chance of working. There's not really an evidence base to support that, not yet. But also evaluating our approach to our co-approaches. Have we learned how to do it better through our processes? Do we have, are we reflecting on the process and everyone's involvement, and whether people are, not being able to have their say or input and that sort of thing. And whilst there are reporting tools and guidance for public involvement, we don't really have that for co-approaches, there's some problems with those tools as well. So as a final point, we've tried in a recent paper to address some of these issues with some ideas around, by no means addressing all of those things, but particularly this idea about a reflexive process and how we might try and reflect on and address power imbalances and promote equity, where we know not everyone will be equal in these situations, but can we promote, at least in the process, some form of equity. This was in the context of implementation research with colleagues in the USA, but again, hopefully there's some principles there that might be useful outside of that as well. I'm going to stop talking now because I know I've run over. I can share these slides if it would be useful afterwards, because the references might be useful. as always, have to put up the funding acknowledgement from our research that I presented. But yeah, let's get into the discussion. Thank you.